Hello, everybody. Thank you for joining us today for our second public health forum. My name is Parth, and if you're here for the first time, this is being organized by Nivarna, which is a public health platform. And today we have with us Dr. Sonali Ved. She has done her MPH from Howard T. Chan School of Public Health. She has over a decade experience in quality care, patient quality improvement. She has worked with the WHO. She has formulated multiple guidelines along with other people. And thanks a lot, Dr. Sonali, for joining us today. She'll be talking on healthcare improvement, what it means and why is it important. And there are more people joining in, so I'll let them in. We'll just start off with a small exercise. I'll be sharing my screen. So I request everybody just sort of scan this QR code, which will pop up. And whatever comes to your mind when you think of patient care quality, just enter it in the box that is provided there. This will build a word cloud, which will help us understand what your perspective is when you think of patient care. This is anonymous, so your names won't pop up when you're typing anything. So feel free to write anything. For people who have just joined, kindly scan this QR code and just answer this question. What comes to your mind when you hear patient care quality? So some responses have started popping up. Is my screen visible? I just wanted to confirm. Can you see the word cloud?
Yeah.
Okay.
You can enter more than one word also. There are multiple boxes for entering.
So I think most of these areas will be getting covered today. Efficiency, reduced infections, short-staffed, overcrowded. Because a lot of these things keep popping up every day in the news. Like if you see, mostly every day you'll find some news related to patient getting poor quality or suffering because of lack of staff or poor health system. And in India specifically, I feel we don't address this issue much, which is why we thought to sort of have this forum. So will it be possible for you to take a screenshot of this, Dr. Sonali?
I just did it. I'll do it again because it's been updated. 1 second. I'm just a little slow at this. Just hide the hide results, show Q&A if you can hide that bar. No, show results. Yeah. Okay, doesn't matter. Yeah, if you could. Yeah, perfect. Thank you. Done.
Okay, so I'll hand it over to you now to start with your presentation.
Okay, wonderful. Very nice to see things like care, dignity, ethical, standard operating procedures. Very nice. Thank you all for your inputs. Would love to see some of your faces if you don't mind leaving your video on for some time. It's always useful because we are online. It feels like we're speaking into a empty auditorium. So it's very helpful if some people, oh, wonderful. Very nice to see everyone. Thank you all for making time on a Saturday evening. Many thanks to Parth for his initiative with Nivarna. Do follow Nivarna on Twitter and follow Parth on Twitter, and they have these forums regularly with a variety of topics. So for today, we have an introduction to quality. Let me just get. Okay, so just a little bit about myself. Parth gave a gracious introduction. I've been working in quality and safety for many, many years now. Worked in projects in Africa and East Africa, and a lot of work over the last few years in India and South Asia. So I'm also the founder of Incluve Labs. It's a slightly complicated word, but by the end of it, I think it'll be clear. So include and improve. So that gives you Incluve. And we are trying to make quality improvement and healthcare improvement skills more widely available. Okay, so as promised in the poster, we're going to talk about what is the issue of quality of care, who or what is responsible, why are there gaps, what do we know about improving care, what can we do at our level, is there a method we can use to improve care, and do these methods work in low resource settings? As I continue to save time, I would love to see some introductions in chat. If you could just let us know where you're dialing in from and what do you do, and anything else you want to share. We would love a short intro note from everyone in the chat box. So please go ahead and type an intro. Thank you. So what is the issue, right? So why do we need to talk about quality healthcare? Okay, just a disclaimer. There's a lot to talk about in quality improvement. I can't cover everything today. I'll anyways be talking more than what Parth advised me. So just bear with me. This is just supposed to be like a taster, and I hope it'll give you some words and terms and topics that you can go ahead and explore on your own later. So what is the issue? So I'd love for you, we've already done this, right? So we did that word cloud. What are some of the challenges you have noticed in patient care? And you all did the word cloud on care, dignity, operating procedures, infections, staffing issues, crowds. Hi, Radhika. Good to have you here. Okay. So what is the global scenario with regards to healthcare? And before we begin, I want to talk a little bit about the word quality, right? So we hear this a lot nowadays. 15 years ago, there was no conversation on quality. And now we hear quality everywhere, right? Quality is a noun. Okay, access is a noun. These are all things we want to achieve, right? They're up here. These are the things we want to achieve. It's the what, right? And then how do we get there? Those are the how, those are the methods. So don't confuse the what with the how. So when we say quality improvement, it's a method. When we say improvement science, it's a method which can be applied both to improve access and to quality. So it's not like if I say I work in quality improvement, that doesn't mean that I've never done anything to improve access of care. I have applied certain structured methods to improve both access and quality. Hi, Swati. Hi, Shivangi. So this screen shows a graph from a report that was published in the Lancet in 2018. This is all in the Google Drive folder. In 2018, 3 major reports came out on the state of quality of health services globally. And this was in a large number of countries, 137 countries, low and middle income countries. and the blue is quality and the red is access. So they sort of calculated how many deaths were happening which could be prevented. How many deaths could be prevented if people had good access and good quality care, right? And so how many deaths were overall amenable to having healthcare? And then they divided into how many were amenable to good quality healthcare and how many were amenable to access to care. So if you look at cancer, access still remains a big issue. Red is big. If you look at cardiovascular diseases, access is there. People end up going to a health facility or a healthcare worker, but what they get there is very sub-quality. Tuberculosis is 50-50, access and quality both are issues, right? You can look at this, and this is the global picture, and India is in dark blue. So we have a major quality of care issue, right? So this is what I just discussed. So if you look at the pink column, about 8 lakh deaths in this study were attributed to not having access to healthcare, and about 15 were attributed to not having access to good quality care. So overall, we are losing about 25 lakhs. And in my personal opinion, this is a gross underestimate because they're researchers, they have to be very precise. So they cannot overshoot the mark. So this is a very, very conservative estimate of the number of deaths due to poor quality and poor access. I would like multiply it several times, right? Okay. And when we think of quality, we often think of things like infection, patient falls, bed sores, waiting times, not following the guidelines, right? I would also encourage us to think of the experience of care. We should also think about the experience of care. How are people being treated in our systems? Is there dignity? I like that somebody mentioned that in the word cloud. So also that even though we might have to learn quality of care, quality improvement and other methods at an individual level, ultimately to have transformation in our systems, we need involvement at higher levels. So at district level, state level, national level, there has to be a commitment to not just to the idea of quality and the idea of access, but also the methods of improvement. And if we don't improve quality in the formal sector, people actually even abandon coming to the formal sector. So the first delivery, bad experience, second delivery, home delivery. And this is a quote from Egypt. I will not come to that hospital again. I will not deliver here again. It was very hard. If I deliver again, I will deliver at home. So just improving access is insufficient. Also, people who are from vulnerable populations are worse affected by quality gaps. This was a recent study. On top, there is a recent study from Oxfam in blue. In the study, over 20% of Dalit and Adivasi respondents reported feeling discriminated against in a hospital or by a healthcare worker. A third of Muslim respondents felt discriminated against, and we are aware of several such incidents which made it to the news during COVID. And 30% of overall respondents felt discriminated against for various reasons. 35% of women told that they had a physical exam without the presence of a female in the room. On the bottom is a very interesting social media campaign. I think some of you may have come across this. It was done in Bihar with hundreds of women around the issue of dignified healthcare. Excellent. I just mentioned it here. You can Google it online. It's called Khud Se Puche. And they use the safety pin as a symbol of the campaign. And they recorded lots and lots of narratives of women on their experiences and their concept of what is dignified healthcare. So both these are from the patient perspective. We as healthcare workers might even feel defensive when we hear these things. And that's a natural feeling to feel, but it may help us to also reflect that at times we are patients and we are caregivers, and we have not experienced things perfectly fine in the health system when we've been on the receiving end. So our perception as a healthcare worker is definitely that we are doing a great job, and nobody's questioning that. So all the problems in healthcare, which could be solved by one individual, have already been solved. That is why healthcare is functioning, despite lack of resources, despite less than 1 GDP health spend on healthcare. It's working because individuals are working very hard, but something goes wrong when things come together and patients do not get the care that they deserve. So why are there gaps in care, right? I'm saying that people are working hard, but there's still gaps in care. And we can say lots of things: GDP spend in care, lots of population, not enough health workforce, all those reasons. And there's another reason, right? So, it's not that healthcare workers are waking up in the morning and saying that today I'm going to do a bad job. We are all healthcare workers here. Nobody does that, unless you're a little off in the head. Most people just wake up like normal human beings, go to work, want to do a good job, get paid, come home. But healthcare is complex, patients are on multiple medications. They are not very clearly aware of what to do. You don't have enough time to explain things. And with increasing medicalization, things are getting even more complex. This is a very an ICU, some of us take it for granted. If you're working in an ICU setting, it becomes normal to those people working there, but this is very complex. If you look at this, we can spend an hour listing out all the things that can go wrong in this setting. Same thing, in an OT, it becomes very normal to people who are working there, but you can list at least 100 things which can go wrong in this environment, even if people are doing their best. Same thing in an OPD, in an antenatal care unit, anywhere else. We forget how complex the system is in which we are working. This is a way in which quality gaps are documented in literature. This is called the cascade of care. I'm just throwing out some terms and ways here. So then if you see them later, you can recall what was said, and it can also open up avenues for exploration. So, one of the ways to sort of picturize gaps in quality is to use the cascade model. It first came out in HIV, and now it's used for many other conditions. You can use it for diabetes, for TB, usually for chronic conditions. It's a good model to use. So if you look at the graph on the bottom, and I haven't given the reference for this, but anyways, this is on TB. So let's say 100% of patients are sort of individuals who the doctor feels has TB, right? Now, some of them will not get access to a diagnostic test. Then some of them will not get a diagnosis. They might get the test, then they don't follow up, something happens, lab results don't come back, whatever happens, they don't get diagnosed. Then some of them will get the test, get diagnosed, but they won't get registered in treatment. Then there will be those who don't get treatment success, and then those who experience recurrence or death or MDR or whatever, right? So at every stage, there is a dropping off, there is a falling through the cracks. And it is, in my opinion, as soon as somebody's touched any element of the health system, the onus is on us to make sure that these gaps don't occur for any patient, and every patient gets consistent care through to the end, which is not the case right now. So there are many ways to think about quality. These are usually the dimensions of quality. I won't walk through them one by one. You can think about various examples under each of these: safety, timeliness, effectiveness, efficiency, equity, and patient-centeredness. A lot of the word cloud also covered many of these dimensions. So there are many, many, many opportunities for us to improve care, right? Show me a facility where all of this is happening perfectly fine. In one unit in which we had done quality improvement for about 2 years, we finally started working on medication errors. And the nurse there said to me, she called me, she was very worried. She said, we just, did baseline data collection on medication errors. And Dr. Sonali, this is terrible. I've been working here for 30 years. We have a 30% medication error rate. How can that be possible? And then I had to reassure her that if we redo this baseline data collection anywhere in this country, it will probably be 50%. So not all those errors lead to patient harm, but this is a leaky boat. Like in childhood, I don't know how many of you experienced a leaking roof in the rains and running around with buckets. That's how our health system is right now. It is a leaky roof. It's not like you will get wet or sick from that water, because you can put a bucket and you can catch that water from dripping, or you can repair that one tear in the roof. But overall, your system is quite weak. And this is everywhere in the world: US, UK, India, Scotland. This is from another of the 2018 studies. And basically, so when we are talking about all these gaps, a lot of times in discussions, when we're talking about a particular issue in a particular facility, one of the reasons people come up with, staff is not motivated, nurses don't want to do, etc. And I'll take you back to this cartoon, right? Nobody's waking up to do a bad job. And the same sentiment has been repeated again and again by multiple international groups talking about these things. We vehemently reject the idea that the workforce is uncaring. Many workers are ill-served and dependent on systems of care that impede excellence and drain their energy, right? So we are working in systems which are not up to the mark. And we use the word systems a lot in healthcare improvement. And the question is, what is a system? So a system is a series of steps which lead to a particular output, right? So when we say healthcare system, we say education system, a factory is a system, a family is a system, a shopping mall is a system, the human body is a system. These are all systems. So all of these are complex entities which have a structure. A structure can be the building, the structure can be the people who are working on it, their skills, their training, and how the organization is ordered. That's all structure. And then the process, right? How do all those elements which are in the structure actually come together? That's the process, and that's the missing piece usually in our conversations and in our work. So even if you look at a lot of accreditation guidelines and other things, they usually focus a lot on structure. Even the conversation during COVID was number of beds, number of ventilators. And then those of us who critiqued this conversation, we said, where are the health workers? We were still focusing on structure. The conversation still hadn't moved to process, right? What was really happening to the patients in the ICUs with COVID? Were they getting enough contact with their loved ones? Was there infection control? There was extreme shortage of health workforce. So I'm sure process was really, really affected. And till now, there has been almost zero conversation on process. And but it's only when structure and process to come together is that we come to healthcare outcomes. Outcomes will be, did the patient get better? Did the patient die? Did the patient get an infection, etc. Right? So health status basically is your outcome of your health system. This is also called the Donabedian model. So till now, I've talked about all the problems in quality and in access. And then if you go and look in Google search, the Google Scholar, and you type in quality issues in, I don't know, in say intensive care, you'll find a lot of studies identifying the gaps and quantifying the gaps. For any issue, you type in tuberculosis, you type in diabetes, there'll be many, many thousands of studies which are quantifying the problem in various settings. These are important, right? They give us, they help us write grants. They give us something to begin with, like a basis to start talking about that this is a problem. But where are the studies which tell us what works and what does not work to solve these gaps, right? So there is much less, it's increasing now, but there is much less work on solving these issues than there is on quantifying the problems. And I like this quote from Mary Dixon Woods, which is, we need to stop admiring the problems and we need to start investing in evidence and in work to solve them. So how do we solve them, right? What works to improve healthcare? So this is a big table, but don't worry about it. Just for those who like evidence, the rest can ignore this. This was a study by Rowe et al., who analyzed various methods of improving healthcare quality and tried to quantify what works, what doesn't work. And they put quality improvement under group problem solving. And interestingly, according to their analysis, it seemed to work a little better than even strengthening infrastructure, than even incentives. So if you look at the bottom, health system financing, it was 1.2, strengthening infrastructure was 13, group problem solving was 28, right? So just having inputs may not necessarily lead to good outcomes. We need to work on the process piece also. Okay, so what does this really mean? Like I keep saying, quality improvement, healthcare improvement. This is a study from, this is an example of a project, and there are many such examples online. This is from Himachal Mandi. This was, I think, way back in 2015-16, and authored by Nigel, Praveen, Devinder. Yeah, I was also on this project. We use this because it's a clear example. So this is a hospital. This is antenatal care. We are supposed to measure patients' BP and hemoglobin. It's supposed to happen in every antenatal care clinic, right? So they did baseline, right? So half the patients didn't get, more than half HP not measured, about 30% BP not measured, right? So about 50% of the clients are not getting the care that they receive. And this is nothing complicated. This is relatively simple if you look at all of healthcare. What we do when we do QI is we avoid using cross-sectional data. We use data over time because that gives us a better picture of what is happening. So if you look at this graph, if you look at week 3 and look at the blue line, July 13, week 3, it's almost at 100%, right? And then you look at October 13, at the green line, it's almost at 30%, at 100%, right? So just keep that in mind. Okay. Right. So what are our options when we look at this issue, right? We would like both lines to be consistently at 100%, but they are not, right? Plus, we are not identifying any high-risk patients, right? So I think it's just moving on its own. 1 second. Okay. So if we think this is an individual problem, that healthcare workers don't have the knowledge, don't have skills, or don't have motivation, then our usual solutions are training, right? If they don't have skills, we need to train them. If they're not motivated, we need to give them some incentives, which could be financial, non-financial, or they don't know things. So maybe we can put posters on the wall, right? This is where our mind usually goes, or they might need some supervision because they're not doing their job properly. However, if we assume, going back to the cartoon in the beginning, that everybody is coming to do a good job, and remembering that quote that health workers are impeded by the system in which they work, then it's primarily a system problem, that there are certain barriers in our system, the way the work is organized, that the staff is not able to do their job. So if we start thinking in this way, then the solutions that we offer will be slightly different, which will be either management related or process improvement, right? So what does this team do? I can't teach QI. We are already near the end of the session almost. But what this team actually, what the people working in this facility actually did was they basically did 4 steps. They got together because they realized that as an individual, I can't solve this issue. There is something happening here, which maybe I'm not aware of. When I come, I measure all the BPs, but something goes wrong. They decided what is the exact issue they're going to work on, which is then you write an aim statement or whatever. They decide what they're going to measure. That's why we have this graph to enable this discussion now. They decide what changes they can make in their setting to improve care for patients, right? So they work together on all these things. They have weekly discussions. They have a little WhatsApp group where they share that, oh, today 80% patients were measured. I tried to do things in such and such a way, etc. And the case study link is there in your thing. And then when they started measuring, not only did they start measuring consistently, they also started identifying high-risk individuals, because one of the issues that happens is sometimes people will document BP, but it's not really being measured, right? But in this case, because they were invested in solving the problem, they were actually measuring accurately. So the whole system of care changed. We entered a new world. The world changed, basically, right? And then both the things were happening consistently. Why are we saying that we don't need training in this case? Is because there are days on which we are almost at 100%, even in the beginning. That means it's not a skill issue. It's not a motivation issue. It's not a training issue. There is something else going on in this place, which is hindering people from doing their job. Yeah. This is another way of looking at the same of what we are trying to do here. So we have the knowledge of what is needed. We know the standards, for example, neonatal hypothermia, door to balloon time, central line infections, ventilator-associated pneumonia. We know what we need to prevent, right? We have the skills for it, right? But ultimately, what is the missing piece is how do we bridge the gap between science, our knowledge, and what is really happening to all our patients, not just one patient, but to all the patients that are crossing our path, that are moving through our unit or through our ward. Yeah. This is another example. This was in the emergency department at AIIMS in Delhi. Really challenging because it's an open system. It's not closed like an ICU or a ward. Worked on reducing waiting time prior to first medical contact was almost an hour. And over a period of time, they did lots of different things. And they tried small ideas. And then they reduced it to less than 15 minutes. And you can see all the changes have been marked. And for some of them, they're saying not feasible, not accepted. Right? That is very normal. So when you're trying to improve a system, some ideas will work, some ideas will not work. Yeah? And this was all a group effort. Everybody from the health assistant to guards. In fact, the data was being collected, I think, by one of the guards, not even by a doctor or a nurse. Everybody was involved in this effort. So the idea is how you improve care in a ward, in a unit, in a hospital, is to use a structured improvement method. There are various names you'll come across online, model for improvement, this and that. In South Asia, we're mostly now following point of care quality improvement, POCI. So you can go to pocqi.org. You can see all the materials, all the examples, and you can try to do this in your own setting. So this is how QI works. But you basically do need some sort of an initiation into the method and how to do it with the help of somebody who's done this before. because we are not given managerial skills in medical school. So this is a very new way of working. So one needs some support. So whatever method one uses, one has to apply it consistently. Ye nahi ki 2 mahine kiya, you do it for 2 months and then, all right, QI is done. It has to become an institutional habit. There has to be organizational commitment. It has to be multi-cadre. It's not just something that doctors do for their thesis project and publish it. And it requires some level of investment of attention and resources from the institution or from the government or wherever to keep it happening, at least initially. And then it has to be made part of the system. In the US, you have, one resident will be the quality resident. In the UK, they're required to do QI projects as part of their training programs, right? So slowly, it has to become part of the system. Just a note before we end, you'll come across different terms. Most commonly, healthcare improvement, improvement science, quality improvement, these are all okay. Do not confuse with accreditation, quality assurance, and audit. All of these are different methods to improve care, but they are different. They are not, accreditation is not the same as audit. Audit is not the same as quality improvement. Assurance is not the same as improvement. They all have different roles. They are done in different ways. We can have another session to discuss what are the differences. Also, don't confuse quality improvement with research. There are differences there also, right? So, so this is where we are at. It's just a very rough overview. I could, it was a little bit of a challenge for me to figure out what to talk about here, but I'm available for any questions. And Parth, I can linger after 7 also.
Okay.
That changed. These are the websites and resources, and I'll just post all of that in chat also, which you can follow if there's more interest in learning about quality and safety. It's a journey, especially if you're new to it. There is a lot of stuff out there. There's a lot you can do in your own setting. So I would really encourage you all to start exploring this area. I think we are still at a very nascent stage in India and in low and middle income countries compared to what's happening elsewhere. And I think there's a lot more scope to do things here. In some ways, it's easier in our setting to change systems because we don't have so many bureaucratic layers. So there's a lot of scope to improve things in a short time. So I think I'll end there.
Thanks a lot for summarizing it so well. It's a huge topic, but you have sort of explained it in a very simple way, and thank you for that. We have maybe another 20 minutes. The floor is open if anybody wants to ask anything or share their experience when it comes to quality of care, if they have to discuss anything with Dr. Sonali, or even if anybody wants to build a collaboration here, the floor is all yours. Please just raise your hand and I can go ahead and unmute you after that, if there's anything you want to say. So Dr. Sudeep has sent a message in for you in the chat box.
Oh, that's sort of medical education related. Sudeep, do you want to take the mic and just say what
I'll unmute him.
Maybe there's some link which is not coming out in text.
Hello.
Yeah, hi.
Good evening, ma'am. I'm Dr. Sudeep. Ma'am, I would like to ask that under the current topic, what I consider is that medicos, as we have today in the Indian scenario, they're not adequately prepared because qualifying exam, NEET UG, it is just MCQ solving. So it does not adequately prepare a medico. So I would theorize that we do not get quality medical care in our country because the doctors, they are not adequately chosen from amongst the people. If you would like to comment on that.
Okay, thank you. You're making it a little challenging for me, but I'll try something. Okay, so, oh, wait a second. Okay, so I'm going to try to draw a very bad graph. Okay, so, oh, that's nice. These things have become fancy. Okay, okay. So let's say this is the distribution curve of, how do you say quality of our residents, right? So that's the quality. I think you can make out that's the quality. And these are the bad ones, right? And then these are the excellent ones, right? Yeah, I hope people can understand normal distribution, right? So in every system, you'll have some people who are like really terrible. Most people will be sort of, good, theek, chal raha hai kaam. And there'll be some stars, as we all know, right? Most of us will be somewhere here, right? So one way of looking at the system is, let's just do away with the bad people. Huh? Do we have this option? We don't really have this option because there's a health workforce shortage everywhere, right? The other option we have is, and Indian exams are so competitive that even somebody who gets the last seat in an exam is pretty much brilliant. So I don't think anybody who is joining medicine as a profession, maybe there could be issues with communication skills, etc., because we are not testing them, etc. We don't have any interview process, unlike say an IAS or something, and that can be challenging to set up. But I think anybody joining medicine, at least doctoring, I don't know so much about nursing education, it's just so competitive. So even somebody who's the last person joining in a counseling session is pretty much brilliant. I didn't train in India. I trained in Eastern Europe. So I'm an FMG actually. So you guys are all sharper than me, right? So, so we really have to move away from this idea of bad apples because we don't have an option. What option do we have? So let's look at another reality in which we have, this is our graph. This is our distribution, initial distribution. And then what we do is we improve our system. And I think that was also part of your question, that what can we do to improve, the skills and knowledge of the doctors who are passing out. So if we improve our system and we make it such that we want to move towards good, right? So we make it such that our whole system shifts from bad to good, right? So now we have slightly more good people and slightly less bad people, right? I don't know if this makes sense. It's a little hard to draw, but it's about, instead of focusing on eliminating the bad, what we think are bad apples, they may not necessarily be so. What can we do to enable whoever's there in the system to do a better job, And anybody can do a better job. Otherwise, we would not have interventions like task shifting. In task shifting, we're actually saying that a nurse should do what a doctor is doing and an A&M should do what a nurse is doing, right? So that means everyone's capable of a lot more than what the system is currently allowing them to do. So, that's sort of an indirect answer to your question. So I'm going to close this. I don't know how to close this, so I'll just leave it. But
I hope that answered Dr. Sudeep's query. If there's any follow-up question to that, Dr. Sudeep, you can go ahead. Otherwise, I'll ask Dr. Swati to ask her question next. Okay. Oh, sorry,
No, it's
he's
okay, this
muted.
is-
Okay, sorry.
Yeah.
Yeah, you can go ahead now.
Hello.
Yeah, Dr.
Hello.
Yeah. Go ahead. We can hear you.
Ma'am, I believe that our healthcare system suffers not just because of from the patients and there are problems. It is from the doctors end as well. Because our doctors are not well equipped in the current scenario. I agree there is a shortage of doctors, and supposedly if we pick out only the good ones, there will be an even much more shortage. So, but I think our competitive exams are not equipped to choose the doctors in the right way. I believe the problem stems from there at the doctor's end. And even if the doctors who are chosen, they are not educated, they are not taught the communication skills and required skills to deal with patients.
Yeah, I agree with you on the communication skills. How doctors should be selected, that's a whole different question. And I do believe, irrespective of how doctors are selected, if an individual enters into a system that enables them to perform well, they can still perform well. You know, people like us, I will go and walk around in Delhi, eat something and throw the trash on the ground. When I, the same person, goes to a Western country or even to Eastern, South Korea, I will not throw it on the ground because nobody else is throwing it on the ground. Individual behavior is really, really determined by what goes on around us. Many studies have been done on this. So if we change the environment, behavior can change. Ability to perform better. Why does anybody who wants to do a startup in the US go and live in California? Because then you're in the startup environment. You get influenced, you get inspired, right? I completely agree with you on the lack of communication skills. It's a huge issue. And not only do patients suffer, doctors also suffer. I don't know what's the latest, but I was not given any training on breaking bad news or announcing death or intimating somebody of a terminal illness. All this can become very heavy for the practitioner to bear. So it's a very important issue. I believe in latest reforms, there has been some addition of all of this. You know, my only encouragement is if you weren't taught certain skills, ethics, communications during your course, there are many options to study these things now. Sangat runs very good programs. Join them, spend some money, and learn these skills. Same goes for quality improvement. You know, we are not taught these skills. So we always feel कि यहाँ तो ऐसे ही होता है, यहाँ तो कुछ नहीं बदलेगा. Because we've not been able to effect change in our environments because nobody taught us basic management tips and techniques. I'll move on to Swati now.
1 second. Yeah.
Hi, Dr. Sonali. Thank you so much for summarizing, as Parth said, summarizing this vast topic into a very comprehensive presentation. So I would like to ask you from your experience, have you noticed that and leave the doctors, but rest of the healthcare workers or the supporting administrative staff, all of them, do they benefit or will it lead to more quality of care when they are trained more in an observership based manner than giving them theoretical training? Like I understand that we are talking in a situation where we don't even have a formalized format for training when they enter the health services per se, if you talk about the government system. So do you think allowing them to observe somebody senior to them or somebody who has joined the service previously to them, shadow them for a while and then later take up responsibilities would lead to delivering more quality care as compared to putting them right into a new environment and dumping things on their head?
So I'm not going to go into what I call technical or content skills, right?
Mm.
So it's a nurse, does she know how to give an injection? Is it if it's a health assistant, does he know how to use a wheelchair, right? I'm not going to go into that, right? I'm going to go into, that's more of a pedagogical and a training issue. I'm going to go into what is the way to help anybody working at any level in the system to realize that they have a very important role to play. So a guard's role is not just to show away patients, right? So imagine if you're doing the job of a guard in a hospital and the whole day you have to keep saying, no, no, shooing away patients in desperate need. That's a very emotionally draining job. But what if you're called to a meeting and you're told that you play a very important role in recognizing a chest pain patient and speeding them through and saving their life? Your complete motivation for your job and for knowing the technical aspects of your job completely changes. What if you're a guard in front of an ICU and you're told that your job is not just to keep stopping people who are desperate and crying from entering the ICU, but your job is to prevent infections and save lives by making sure anybody, doctor, nurse, patient, visitor, is using hand rub before entering? Your complete motivation will change. And if all the staff in the hospital are thinking like this, just imagine the transformation in patient care. Like, it boggles my mind. I can't even imagine it. Right now, most people's motivation, forget guards and health assistants, doctors, nurses, there's a sense of apathy because people do not feel that they can change anything in their system, right? So once they do one little thing to change something in their system, which was irritating them or their patient, or which was stuck for years, then they feel energized. Then there's a sense of autonomy. It just changes everything as a human being. We don't want to be robots.
Absolutely, I agree with you. Thank you so much for that answer.
Book recommendations. Oh, okay. I'll have to look for book recommendations. So there are many on quality of care. Atul Gawande, one who writes a lot on quality. Many others. Oh, In Shock, Rana Odish. Do read this book. Slightly depressing, trigger warning, but powerful, written by a healthcare worker, intensivist, who was admitted in her own intensive care unit. Yeah, thank you, Anand. I'm sure others will have Every Deep Drawn Breath, Wes Eli. We'll post this on Twitter also. Oh, there's like many. Yeah, wonderful suggestions, Anand. Thank you so much. Yeah, so literally all of management and leadership literature, actually, if you get to it, and anything by Atul Gawande is a good read. Yeah. So there's a lot out there.
I feel even when you read about Dr. Paul Farmer, it also comes to quality of care.
Yes.
So even Mountains Beyond Mountains, or his other books, all of them just talk about improving quality of care.
Yeah, so Paul Farmer was one of my inspirations. I had the good fortune to see him in person once or twice, never met him or worked with him, but structural violence is an important perspective. So, any other questions? Somebody asked, can we do things at a district level? Districts are very important in health systems because they're sort of these manageable units. Me, along with Ankur, one of my colleagues, we worked in Bangladesh for a year and a half. We actually sat in on district meetings, etc. So there are certain ways in which we can improve the responsiveness of these sort of management units towards health facilities. So that's a whole new area. But yeah, district level management and what they do has a huge impact on what goes on. Yeah. Hello, Dr. Sita. Good to see you. Thank you for joining.
If anybody wants to ask anything else or share their experience, you can raise
Someone
your.
had asked, what can a JR do at your own level?
Yeah.
You know, needle stick injuries, educate everyone about needle stick, have a session on respectful, dignified care during delivery. There are many things you can do at every level. Wherever you see people are not following guidelines for a certain disease, say diabetes patients are not being told to get their eyes checked, you know, do something about it, talk about it. Not everything will be successful. I had a lot of unsuccessful things I tried to do during internship, but it keeps your initiative alive, and something may work, right? So, and learn. If you want to learn a specific method to improve, then learn about quality improvement. I posted one course, which is their point of care quality improvement workbook. Sudeep mentions.
Yeah, Reem, I think you have something to ask. Please go ahead.
Yes, thank you so much for the book recommendations. Yes, regarding Paul Farmer, yeah, I'm looking forward to read that book soon. There's one written by about him, and I can't remember the name, but next time probably I'll bring up that name in the group discussion. But yeah, thank you for the book recommendations. I wanted to know how can we, as you said, in the district hospital level, like, you know, it's good to take the initiative to improve the quality. So I was curious to know how do we take the initiative at a district level or maybe a level lower than that?
Are you working at a district hospital?
No, I'm not working, but then I did 1 year rural service. So I was posted in district hospital, and like I really observed some things over there. So I really wanted to know what can be done. Like I'm really curious about it.
What did you observe?
Like things were not as organized as they were supposed to be, and like they were very unorganized. So so yeah, and there were a lot of patients who came coming back after a surgery or after any treatment with complications. So I did notice that as well. So I thought that this would require quality improvement of some sorts. So yeah, I was curious.
So you know, all I can say is that learn quality improvement. There's a stepwise method you can use. Maybe we can discuss in one of the Thursday sessions in a little more detail. By the way, I host Thursday QI Thursdays, free to attend. I've shared the Zoom link in chat. Everybody's welcome to sign up. You know, a simple thing, say for example, once where I was working, I think women were not getting enough iron tablets or they were not compliant. You'll have to start by talking to other people, you know, talk to a few nurses, whatever issue you see, talk to a few doctors, a few nurses, get them interested in the issue that you want to solve, and then, you know, narrow it down. Don't try to do 100 things at one time. Pick one small thing and then work together to solve it. That's all I can say right now in the short session. Otherwise, we'll launch into a 1 hour session on how to do quality improvement.
But I feel Include Labs is a great platform to explore these questions. And like you mentioned, you know, like last Thursday, I attended your session and it was pretty good this Thursday. So I think that's something people could do. And like Dr. Anand is saying, develop empathy, quality will follow.
And yeah, Rima, go ahead. Reem, go ahead.
Also, other thing I noticed was that like the ACLS and BLS, like the basic life support was not practiced over there. So there are these mini ICUs in the hospitals, but then when the patient goes into cardiac arrest, no one knows how to perform a CPR. That's very basic, and even the defibrillators are not very accessible. So knowing how it can change a person's life in minutes and seconds, that's very crucial. So if quality improvement is there, probably like a lot of lives can be saved and a lot of improvement can be made. So I was very curious to know how to.
And I like your way of looking at things. You're looking at very specific issues. These are, and you might think what else to look at, but some people find it difficult to narrow down on specific issues which are not working. So this is the start. So you already have a good way of looking at the system around you and observing things. I would suggest keep learning, stay curious. It's not easy to build these kind of skills in one day. If you are in a clinical environment, we can talk and we can figure out if you can work on something. Yeah.
Yes, I would love to. Like after my exams, probably I will
Sure.
come
Let's
back to you, ma'am.
touch. Yeah, wonderful.
I
Thank
have
you.
one book recommendation in case you haven't read of this. It is Prescription for the Future by Emmanuel Ezekiel. I don't know if you have read it, but
No, I haven't read it.
it's a good book. It's a good book. I've started reading a little, but then it's a little difficult for me to grasp it because it's mostly giving examples of American healthcare system. So I haven't really understood American healthcare system yet. So yeah, I think you would like it. So yeah.
Thank you, Reem. I'll check it out. Thank you.
I think Dr. Sita can go next.
So Sudeep also mentioned that deficiency from doctor's end as well. Definitely, right? We are not perfect. And sometimes we don't even know how we are performing. Like that nurse said, I didn't realize that 30% medication error in my unit. So I actually appreciate Dr. Sudeep saying this. The reason I keep emphasizing system is because a lot of times when we work on projects, the first cause that comes up when we discuss ki ye gap kyun hai, people say ki it's because people are not motivated, and that's really not the case. But yeah, there are skill deficiencies. People don't know the guidelines, etc. People overprescribe antibiotics. So yes, absolutely agree with you that ultimately the system is made up of people. So it's a chicken and egg problem. Yeah.
And before we go ahead, there is Dr. Anand in the he's giving a lot of book recommendation. I just wanted to acknowledge that all this is happening because of big contribution from his side. So he reached out to me a few months ago and he actually appreciated what Nivarna was doing and he gifted us this Zoom account. So thanks to him that I just realized it's him. Thanks a lot, Anand sir, for this. He wants me to call him AB, he mentioned previously. So thank you for that. I just realized, I'm sorry, I didn't notice you.
Yeah.
I'm Sita. If it's okay, can
yes,
I
please
just
go
say
ahead, please
a word?
go ahead.
Yeah, thank you. You're all much younger and doing wonderful work. Coming from psychiatry, where it is still debated, science, it's not science, it's not medical, and so on. So we tend to go and take a user's perspective, my client's perspective. So quality improvement, in my opinion, I could be completely wrong, cannot happen unless our people are participatory. Because our system is still very management and dissociated from our public. And a PHC, the participating community has to be there in the management committee, like the Gram Sabha. Doctors should be part of informal discussions. And that would be driving certain trajectory. I don't know whether that will be the same as in now, and the medical model could incorporate more of social aspects.
Yeah, so definitely. So, and I think there are a lot of community medicine residents here who will benefit from this perspective. Even in quality, we recommend including patients, getting their opinions, if possible, including some on the team. I don't know if Dr. Sita's gotten disconnected or she stopped.
No, I'm still there. I'm still
there. Okay. Even nowadays, if you're publishing work, there'll be a question journal, how were patients engaged in this work? So there is an increasing recognition of this. Some of the best work that comes out of improvement efforts is where patients and visitors and caregivers have been genuinely involved in improving the system. People do find it a little challenging when they start quality improvement because they themselves don't know how to do it. And then they struggle initially to involve patients and communities. But the recommendation is that till you do that, you miss out on certain key aspects of improving. So, yeah, and especially related in psychiatry, community support and community systems are critical. In fact, I don't know how true this is. I'm not a psychiatrist, but I met a psychiatrist who actually said that hospital psychiatry wards would not be required if we actually had proper community mental health support.
I think that's a bit of an extreme, but
Bit of an extreme.
because we are again a country like ours where
Yeah.
the families are stretched to their limits.
Yeah.
My heart goes out to the carers who have very limited support, and they have to care for chronic mental illness sufferers without enough money, without enough support, violence, so on and so forth. I think it's a very, very gray area, and unfortunately many countries took a very extreme step, and then now they are wondering what the heck are we doing.
So some middle way.
Yes, exactly.
Yeah.
Thank you for letting me speak.
Thank you, Dr. Sita, for joining.
I think another 2 minutes we can take any more questions if anybody wants to discuss anything. Otherwise, I think you can just drop in your email in the chat box. If anybody wants to reach out, they can write to you with further questions, or you can write to Nivarna for India. I'll leave the email for Nivarna as well. And you can write to me and I can connect you with Dr. Sonali.
Yeah, please make sure you spell that correctly. Parth and me both have a fondness for difficult spelling names.
Yeah, it's not Nirvana. To anybody who was thinking it was Nirvana till now, it's Nivarna.
And it's not inclusive, it's inclusive. So very, very happy. Thank you all for joining on a Saturday evening. Just Google online quality, safety, improvement science, and a lot will show up. Start exploring, start thinking about how you can do it in your own practice. I'd be happy to stay in touch. I'll just drop in my email address also.
And just to introduce our next speaker, she's already here with us today. Dr. Swati is there. She'll be talking about TB care in India, what's happening with tuberculosis in India on 28th of January. Tentatively, we haven't confirmed the date yet, but most probably 28th of January. So she's there. And please do join in for the next one as well. It's going to be really interesting. Because
Thank you.
TB is a huge issue. And now that we have heard of quality of care, next we should move to TB and discuss how we can do something about it. So
Yes,
thanks a lot for joining us today. And we hope to see you all again in the next session. Have a good evening and a good weekend. Thank you. Bye.